be perfectly on time? Okay. So thank you for being here. I am not the planned chair. The planned chair is Jane Montaigne. He's the head of the unit where I work. I'm a head of sector at the European Union Drug Agency, and I work in the support to practice sector. So it's important I'm here to listen to you. We will hear from 4 speakers, because they are one. Yeah. And we will have some questions and some debate in the end. And now I will use my wonderful technical skills to read the names. So the first presentation is by Valentina Mancuso and Amani Mahmoud Moha. Amani, okay, thank you. Thank you, thank you. And the title is Harm Reduction in and Out of Prison Project, Holds, Wixie Groups, etc., etc. Okay? Yeah. So thank you, the floor is yours.
Thank you.
I think so.
Okay, start. Hey, okay. Hello, everyone. We are very happy to be here. I'm Valentina. I'm an educator, and I'm board member of UNAIDS. She's Amani. She's a cultural mediator. And we both work for the Isola di Arran association, one of the first association of people use drugs in Italy. And today we would like to speak about our project, the harm reduction in and out of prison project. Okay. Next. Okay.
Thank you.
Next slide. No? No?
1 second.
Okay, we're done.
Please.
Okay. Okay, thanks. Okay. The situation in Italy is very critical, like you can see from the prison data. So we decided to divide our project in 2 actions. The first actions is harm reduction group sessions, and the second action is harm reduction prison release kit.
Okay. The group sessions are held on a weekly basis, Monday morning for the female ward and Monday afternoon in the men's ward. And we do talk about a lot of things, but one of the things that comes that was really necessary was the fact that some people go to prison and they're healthy, and then they come out of prison with HIV or hepatitis C, and that's due to drug use in prison. The prison release kit is something which we decide what to put in with them. It's individually based, and it's not just concentrated on health. There's also social inclusion thought about there.
Okay. Okay. These are our topics, group session topics. So we speak about what is in general harm reduction. We speak about which type of drugs are on the market, the different types of drugs, the effect, the interaction, the polyuse of drugs, and also we speak about human rights and the rights of people use drugs with inmate people, both in the male and female blocks.
It's harm reduction as an umbrella title. So drugs are at the center of them, but it's not just that. I mean, health is important, but also the political side of things, the social side of things, the economic side of things. We go into that with them. We start very softly. We start at ground level, and then we just progress and do different areas. One of the things that we did was the tattoo workshop, which was not originally on our list of topics to bring into prison, but it's something which does happen in prison. DIY tattooing in prison carries many risks. So we've had a professional tattoo artist come in, right from the history of tattooing, all the different contexts that happen, and especially tattooing in prison, the cultural prison context, and the health-related risks, obviously. The last rectangle there is our local services map. And this is something which it's a leaflet which we give them with what's available for harm reduction locally, but not just drop-in centres or the mobile unit, for example, because Valentina's an educator and she works in prison and she works in the mobile unit. I work in prison, I work in a dormitory, and I also work at the drop-in. So some inmates we already know from the outside, other inmates we get to know inside. And it's great because they're lucid. They're lucid and they're relaxed because they can't go anywhere, and we just spend an hour and a half together and everything comes out. And then they know where to find us when they're out.
Okay, this is our prison release kit. The woman in photo is Maria Teresa Ninni, is present here. She is one of the most important activists for the rights of people who use drugs in Italy, and she is also the president of the L'Isola di Arrana Association. It's thanks to her for this project, and the contents of our kit are there. The most important for us is naloxone, but not only.
One of the good things about Italy, one of the few good things, is that naloxone is prescription-free, so anybody can get it over the counter. When they decide that they want to use again when they're out, there's all the sterile equipment that they need. Even if they don't, we always say, but if you know somebody that uses opioids, why don't you just take the naloxone just in case? But it's not just about health, it's also about social inclusion, it's also about restoring a bit of dignity. So if somebody doesn't have somebody there to get a ride home, or if somebody doesn't even have a home, having that toothbrush and toothpaste and that packet of tissues and that bus ticket, it makes you feel just that little bit more thought about when you leave. Okay, these are some kits that we prepare in prison, and we leave them at the storage area where they keep their personal effects when they leave. And one of the problems we encountered was with just naloxone. Specifically, we took a kit to the storage area, and the warden said, no, that's a pharmaceutical, I can't keep that here. And so we had to take it all the way to the prison governor to get it authorized that they can keep it for them. And we manage. So it's a complete kit if they want it. The photo is the brainstorming we do right at the beginning when we introduce that umbrella title, harm reduction, and what they think, what is harm reduction. And the most absurd things come out. But one of the things that we realized is that they don't know their rights. They don't know that access to sterile equipment is a right. They don't know that access to drug checking is a right. And so it's interesting, it's fun. Drug wheel, we use it as a game, and so they're there drawing labels with the names of substances on them. And it's not necessarily the substance they use, so they've got it there and they think, what do I do with this? Where does it go? I've no idea. And then somebody else in the group says, oh, I use that. I know where it goes. And there's that exchange between them where they learn from each other. And then we go on to the TRIPSIT table. So we've got all those substances, all those drugs they use, and then there's all the interactions when they mix the stuff and they think, okay, light bulb comes on. That's why I felt so sick when I mixed them. And it's fun. It's fun.
Okay, this is a campaign slide. We present our campaign, so the World Overdose Day on the 31 August. We invite an expert and we talk about the different type of overdose. And we present recently also the the 16 Actions Day of Eva Wood campaign is a campaign against elimination violence against women use drugs. And we are very, very happy to present this campaign inside both in the male and female blogs.
Okay, we touched on the fact that prison staff aren't very clued on what harm reduction is. So next year, when we take this project into prison, we'd like to have something which has to do with training prison staff. We'd like to consolidate what we do with the topics, maybe increment them as well. The tattoo workshop, which was really successful, we'd like to have a more structured intervention there. And also something that came through is the fact that inmates help inmates. Who's more clued on legally or with health issues, they help each other. And so we'd like to somehow structure that and help them to get what is rightfully theirs within the prison system. Okay, we're here to say thank you, but we're here also to tell you that QR codes there is our full project report. So you can find out a bit more about our association, you can find out a bit more about the project, and there are all the individual session group meetings there, what we did, how we did it, the material we used, etc. Thank you very much.
Thank you very much, and we keep our questions for the end of the presentations, and I will introduce the next speakers. The next speaker is Wes Steele. Okay,
that's me.
Thank you.
Is that working?
Yes.
Awesome, brilliant. Yes, so my name is Wes Steele. Thank you very much for the invite. Please give me a wee cheer if you love peer-powered harm reduction. Awesome, brilliant. I'm in the right room then. I know I'm in the right room. That's amazing. Thank you very much. So, saving lives, peer naloxone supply in Scotland is what I'm here to talk to you about. My clicker is not working, which is always helpful. Yes, please. Thank you. So just to give you a wee bit of a background, unfortunately in Scotland, drug deaths continue to be a public health emergency. We had 1,172 drug-related deaths in 2023. 80% of those had opioids directly implicated, so the vast majority of people tragically die in preventable deaths. Opioids are definitely implicated. More than double from just 10 years ago. You're almost 3 times as likely to die in Scotland as you are in the rest of the UK, so we really are in the grips of a public health emergency. Forward-facing staff, unfortunately, suggesting things are not improving for us, so we've definitely got a long way to go. So that's just a wee bit of a breakdown of the different opioids that are present. To just kind of show you the significance and the importance of improving naloxone provision in Scotland. So why peer supply? So I would argue that peers have privileged access. They can go to places that normal members of the community or professionals are unable to go. They have an increased reach into the most at-risk communities. And they have instant credibility. People are much more open to harm reduction messaging from someone of a similar background and experiencing similar support needs. Over and above this, I would argue that we have the most skin in the game. We, alongside the families, I would argue, have the most to lose. We are burying our pals, and we have been burying our pals for years, and if not decades at this point. So we do have the most kind of to lose. And it's important, thank you, it's important, in my opinion, to be empowering the people most at risk, to help reduce the deaths within their own communities. You know, rather than harm reduction being interventions being done to communities, we're doing harm reduction interventions kind of within the communities. I will try and slow down. We had 3 key objectives to establish, embed and support high quality peer supply of naloxone as a core service right across Scotland. We wanted to ensure those involved in the intervention have an active voice in the delivery of that, but also other harm reduction strategies locally. So we're really trying to involve the voices of lived and living experience, and then also to just connect with and support any other external unfunded projects that are doing peer naloxone supply. So a bit of a breakdown, we did quite a lot of community work, which we really enjoyed. One of the innovations around the community work we were able to do initially is we had a budget, so the peers making the supplies were paid as sessional workers, and to me that was a first in Scotland. Previous models were volunteers, so we thought it was really important that people were sufficiently reimbursed for their time and their expertise and their skills. Amir, please give us a wave. So I have to name check Amir. Amir was one of our first community sessional peer workers. He now has joined SDF in a national role and is helping us kind of roll out the project. We've also had peers enroll in the national traineeship, where it's almost like an apprenticeship. So they go on to get a qualification and do paid placements. We're in 7 prisons up to this date. And I just want to emphasize the importance of the physical supply model. So to the best of my knowledge, this is the first time we've got residents or prisoners in prison training and supplying prescription-only medicines to other residents or prisoners in prison with no staff involvement. And for me, that's really kind of helping increase the uptake. Year to date that we've got data for, 47% of naloxone from prison was made by peers. The time period we've got this data set for, we were probably in about a third of the prisons. So again, we're massively increasing the number of kits going out, and as we continue the rollout, we hope to kind of see that increase. It sparked the creation of a national framework, so any prison in Scotland can now adopt this model and make this model possible. Effectiveness. So to date, just shy of 5,000 kits have gone out from all the projects that we've kind of led on. Like I said, some of those were community work and some of those specifically in prisons. But over 75 of the kits supplied by peers were first time somebody that had ever been supplied that kit. So again, I think it's really improving coverage. And peers have worked over 5,500 hours, with the vast majority being paid for their time and their expertise. I think the sky is the limit. I would love to see peers doing much more harm reduction intervention work around dry blood spot testing, safer injecting advice, even IEP, giving out needles and syringes and stuff. And I think embedding peers within existing staff teams really increases the skill mix within that team. And this is what we've seen, and some of the feedback we've had from partners is it really diversifies the existing staff team that are kind of present. A wee bit of the learning so far. Unfortunately, sometimes there is still a reluctance to employ people that are still using drugs or even on prescriptions, depending on the kind of progressiveness of the partners that you're kind of partnering with. PVG and payroll timeline, so the amount of time it takes to recruit people, some of the checks people have to go through to work in services and things like that can be a barrier. Culturally, I think we still need a bit of a change, especially in the prison settings. People have kind of alluded to that already, a bit of a culture shift. And, where we have a strong local ally, we're able to set up really quite quickly and it works quite well. If we don't have that initial buy-in, it can really be quite tricky to do. And then some of the facilitators, proactive coordinator locally, having that local buy-in, someone who gets it. And I think for me, it's not really something you can teach. Either people get the importance of peer work or they don't. I don't really think it's something you can kind of impart to people. So I hope I've not run over time too significantly. We did evaluate the 3 of the earliest projects, so please do go on the SDF website, have a look at the formal evaluation. Please do come and noise me up at any of the breaks. If you have any difficult questions, I will field them to my colleague Amir. Thank you.
You are even ahead of time. I'm frustrated. They are too well behaving. I mean, I don't have. I'm really useless here. Okay. I'm sorry for this need to check, but if the next speaker wants to introduce himself, save me some time. Yes.
Hello, everyone. I'm Graham. I'm from England for my sins, and I will try to speak more slowly. I know what it's like to live in a country where the language is not your first. So I've been supporting correlation related to prisons over the last couple of years. Basically, correlation was asked by many of its members about how to get involved in harm reduction in prison, because they recognized that most of clients experience time in prison, often rotating. What's the English word? So they're in and out of prison quite a lot. And then there were those who did not before going into prison, but started in prison. So what we did, and maybe some of you were in Budapest last year, where I outlined module 1 of a toolkit that correlation is. There we go. to ask correlation members and others about their experience of getting involved with prison. And then we wrote up the qualitative data we received, analyzed it, looked at the common elements across all of the interviews, and then developed some recommendations for those not involved in prison. Okay, here we get to Module 1, because Module 1 guided us towards those members of correlation and others who have experience of working in prison. And here's a nice QR code. If you want to access Module 1, it's on the website as well, and you can download Module 1 from the website on correlation. And it all looks beautiful and sexy, and it's got lots and lots of information. So if you really are starting, you know, you can find details, for example, which ministry is in charge of prisons in your country. You know, those fundamental questions you may have. So from the survey that we used for Module 1, we had a good idea who was working in prison. And we contacted them. You know, some were very busy, of course, but these are the ones that we were able to interview. So, you know, Belgium, Germany, Italy, Moldova, Portugal, Ukraine, England and Scotland. So we had a set of 12 questions that we used as a guide. You know, the fundamental things that you would ask. How did you first get involved? You know, did somebody approach you? Did you knock on doors? If yes, which doors did you knock on? You know, really basic kind of stuff. Most of the interviews were done by Zoom. It lasted about 1 hour. And a lot of the work was done by Mariana, who's sitting over here, looking very shy. I did a few as well, and then Rafaela did the oversight to make sure we kept on course and such like. So what are the common elements we found? Well, first, there's very few civil society organizations involved in prison. We also found that government agencies asking for CSO help was the most common, whether that be for harm reduction or for general health. The other thing that really came out was you have to be patient. It's a very long process. Even if the government has maybe put out a request for proposals for civil society to deliver X, Y, and Z, even that, it's a very slow process. Also, the regulations for access can be difficult to adapt to. And to be honest, this fits with what Wes has just said about, you know, peers inside a prison. They're already there. They don't need to go through lots of regulations to gain access. So that's a plug there. And opportunities to have private, confidential, one-on-one discussions can be very limited, because often those from outside are followed by prison staff for safety and security reasons. Other common elements, services tend to be narrow in scope rather than broader health. So it might be for one specific intervention. So the idea of helping a person as a whole is very difficult. Security is prioritized over health. And, you know, I think it can be very frustrating. And it hinders the comprehensive package of services that people have a right to use if they need to. Funding cycles are short term, and contracts tend to be short term, so, you know, 1 or 2 years at a time. So, as we'll see, in the recommendations, you know, one of the things is to build relationships over time. But if your funding is short term, it can be very difficult to keep those relationships building. If there are funding opportunities from government, that does seem the easier way of getting your foot into the prison. Either that or rob a bank and go in and be a peer. Yeah, building trust with the prison management and with prison guards is crucial. Also to collaborate with other healthcare providers. And really this idea of a long-term perspective. Don't expect to build Rome in a day. But that's an English idiom. My apologies. So really strategically, even if you don't have any money, you need to think longer term and try to keep building relationships wherever you can with people in the prison. And also understanding the prison culture, you know, practical solutions that are measurable is also important. Comprehensive training programs for both the prison staff and for prisoners is a recommendation. Again, taking small steps, identify the key services that you can deliver, maybe more low-hanging fruit, education, counseling, mental health support, rather than going in and trying to set up an OAT program. You know, start with the simpler stuff. Apply for prison partnerships where they exist. Peer-led programs can be very effective. And then the reintegration and post-release that our colleagues were mentioning is another way of getting involved and to build coalitions with other CSOs. Just to add one more thing, is one way of learning about what's really happening in the prison is to meet people coming out of the prison. It's not only a good opportunity to support their harm reduction, you know, refill of naloxone, etc., but once they're out, they are in a safer situation to tell you what are the services available, rather than what you might be told officially, which can be very useful. So there we are for Module 2. So we're looking for funding to continue on the journey, as we say. Thank you. I hope my English was okay.
Yes, you got the 3 minutes bonus. Last speaker, you kindly introduce herself.
Hi everyone, my name is Tatiana. I represent Ukrainian NGO Free Zone. So let's start. Allow me to present the key developments in harm reduction initiatives within Ukraine's penitentiary system and the achievements made possible through collaboration between state and non-governmental organizations. Okay. As of October 2024, 40,784 prisoners are held in places of detention in Ukraine. The system includes 56 correctional colonies and 25 pretrial detention centers. In 2023 alone, 9,221 individuals were released from correctional institutions. Despite the system's scale, access to harm reduction services remains inconsistent, posing significant health risks to inmates. An anonymous survey conducted through the Free Life app revealed that 60% of convicts have experience with drug use. To address this, 19 new opioid substitution therapy offices are planned to be open in correctional institutions by the end of 2024. For people who inject drugs in prisons, the following services are currently available: pretrial preparation to support reintegration into society, post-release support for continuity of care, opioid substitution therapy, and needle exchange points. But it is important to note that OST and NAP services are not available in all correctional facilities yet. To address these challenges, harm reduction has become a priority for the Ministry of Justice in combating socially dangerous diseases. Key measures include developing legal frameworks for the implementation of needle exchange programs in correctional institutions, training peer-to-peer social workers selected from among inmates to deliver harm reduction services, preparing methodological recommendations and implementation algorithms for NAPs, and launching pilot projects to integrate these services into the penitentiary facilities. An anonymous survey conducted via the Free Life digital app revealed that 51% of inmates have a history of drug use. Many reported participating in opioid substitution therapy programs before incarceration, while others disclosed engaging in high-risk behaviors such as needle sharing and frequent drug use within detention facilities. A total of 508 inmates were served in Odessa Correctional Colony number 14, and 395 inmates participated in the survey at Strizhavka Correctional Colony number 81. The Free Life survey highlighted a critical need for harm reduction services directly informing the NSP development. The pilot harm reduction initiative began at Odessa Correctional Colony number 14 under the State Criminal Executive Service of Ukraine Health Center ODA. It introduced a comprehensive service package, including the development of training modules for social workers, capacity building session for medical and non-medical staff, and provision of tablets for peer consultants to facilitate service delivery. Building on this success, the program expanded to Strizhavka Correctional Colony number 81, making it the only institution in Ukraine offering both OST and NAP services. In October 2024, a state-funded harm reduction model was introduced, ensuring program sustainability. The model operates through partnership with NGOs, where the Public Health Center contracts organizations like Nezalezhnyst and Free Zone to deliver NAP services in correctional facilities. From April From April 2023 to September 2024, the harm reduction programs yield remarkable outcomes. 1,000 inmates accessed NEP services across 2 colonies. 66,000 syringes were distributed to reduce needle sharing and associated risks. 10 prisoners were trained and engaged as peer-to-peer social workers funded by the Global Fund. And since October 2024, a state-funded model to harm reduction services in prisons has been successfully implemented, ensuring sustainable financing and broader access to these vital programs. Looking ahead, the NEP model will be expanded with the establishment of 2 additional programs in 2024-2025. Legal and methodological frameworks are being further developed to institutionalize harm reduction across the State Criminal Executive Service of Ukraine. The success of the pilot project at Odessa and Strizhavka correctional colonies highlights the transformative potential of harm reduction programs within the penitentiary system. These initiatives not only improve inmates' health and safety, but also promote social reintegration through peer-to-peer engagement. By leveraging innovative tools such as Free Life app and securing sustainable funding mechanism, Ukraine is setting a precedent for expanding harm reduction services across correctional institutions. Continued collaboration between state institutions and NGOs remained critical for enhancing public health and fostering long-term positive changes within the penitentiary system. And here you can find the QR code, following which you can download Free Life app for iOS and Android, and also check our official website. So thank you for your attention.
Thank you very much. And we gain a speaker that was lost. Matteo, is it your name? Do I remember? Mauro. Okay, I tried. Okay, go ahead. Yes.
Thank you very much. Sorry for delay, but I just arrived from Mexico City, so it was quite a miracle to be here after a very long trip. My name is Mauro Patti. I'm here representing the Villa Marini Foundation, who's collaborating from years with Correlation. I'm very glad to be here represent our foundation. Where should I? This way. The direction. The other one? Rotate, okay, fine. Okay, cool, thank you. So, Villa Marini Foundation has been established in 1976 in the city of Rome. We are the Italian Red Cross agency on substance abuse, and we serve as a hub, a research center and training center for the International Federation of Red Cross and Red Crescent Society. Our methodology is to adapt the therapy to the individual and not vice versa. And we provide a wide range of treatment possibilities from very low to high threshold services, trying to apply the so-called continuum of care. Today I will introduce you to some of our services at a very low threshold to the low and mid thresholds, so the emergency unit, the prison project, and the full residential program. Talking about the prison project we established in the 90s, we bring psychotherapy and counseling inside prisons for drug offenders. We serve the 3 main prisons of the city of Rome. We try to address health and mental health needs every week in the prisons, and we also do assessment to find eligible people to the alternative to incarceration programs, and we also support people in home arrest. We do receive metal from all the countries, and we provide free counseling to lawyers, judges, and health professionals in the system. data from last year. So in the city of Rome, we met 81 people. We did more than 120 therapeutic sessions in the prisons, and we had the chance to divert people to treatment program in Villa Marini Foundation, 27 of them, and we received requests from more than 300 people. We started this program in 2001. So far, we hosted in Villa Marini Foundation more than 700 people. When we have the chance to host people in our clinic center and recovery center, we can do this by the law, just for sentences up to 6 years for non-violent offenses and up to 4 years for violent offenses. We provide therapeutic programs, personal psychologists. One of our assets are the peer, so the former inmates or former drug users or educators. We provide activities to them during their stay, like sports, school education. We collaborate with NGOs that support them to improve their skills to find a job when they go out. We actually have also a cooperative that provide a job when they finish their treatment path. During the years, we also had the chance to develop a European program to show evidence to our authority and stakeholders that show that treatment outside the prisons are better and increase the possibility of employment, increase and improve the family relations, and most of all, decrease the drug relapse and also the criminal behavior. One of our services is quite unique in the scene in Italy and in Europe is the Emergency and Prevention Unit that actually is a specific service to address all drug-related emergency in the metropolitan area of Rome. We have a professional team with a medical doctor and a peer that are ready to intervene 24/7. We have a hotline, so people can call us for overdose intervention. If there are people that have withdrawal syndromes in the street, when people are arrested, if there are some family crisis and violence in the streets, we can intervene. Most of the call comes from the police station. This is a very important service that is not established by an MOU, but it's just a practice that started in the 90s, and it's worth it because we try to really show the law enforcement how it's important to collaborate with health workers in this field. We try to build dialogue, awareness, and we do our advocacy towards the law enforcement, also towards the justice systems. The most important outcome of this project is that we reduce the harm and the violence during the custody. And this is very important that we establish a very peaceful settings that is important for our job. This is a map of Rome. So we have close to the center our clinic center and emergency unit. We have 2 standing caravans in the central station of Rome and in one of the biggest market for drugs in Tor Bella Monaca, in point 2, where most of the people are buying and using drugs. We cooperate with all the volunteers of Red Cross in 36 local branches. And as you can see, the police station are 14 and the Carabinieri station are like 89. And they used to call us, as I was telling you before, every year we receive almost 1,000 calls for intervention, mostly from Carabinieri and police, from courts and also from hospitals, because when people have some withdrawal syndromes and are in emergency unit, they need to be supported and treated with medical assisted treatment. One of our Also, aim of this program is to educate and raise awareness towards the law enforcement and also to prison staff. So we provide training courses in our center. We have periodic meeting and dialogue with the judiciary system. We invite them in the panels. We invite them when our clients finish their treatment path. And this is very important activity. By our experience, we report that people, especially in the street, have fear of police, and this is the major barrier to accessing health services. That's why our asset is to get the support of the volunteer Red Cross, because the emblem, especially towards the migrants and people who are most marginalized, can really facilitate our access to them and try to engage them in some recovery or treatment path. One of our ongoing programs is these like a deflection program, so that people that see the citizens that see people are using drug in the streets, or they can find some syringes, they can call us instead of the police. So we can get there, we can try to meet the people, meet their needs, see if they need a night shelter, if they need a drop-in center, if they just need a shower, so we can start the the engagement. Of course, we force nobody to be in our cleaning center, but we establish a relationship, and the trust is the most important asset that we try to build with these people. One of our international initiative is called Rome Consensus, and is a open platform that is established by the Red Cross and Red Crescent, and is open also to NGOs, professional activists in harm reduction. Part of our supporters that are from the States introduce us to the deflection strategy, which is very important, because instead of utilizing a traditional police intervention, deflection relies on law enforcement to be the referral source to community-based drug treatment prior to potential crisis and violence. And another important outcome is that we try to engage the first responders, so not just law enforcement, also the Red Cross people, and also the people are working in the streets, to teach them how to use naloxone in case they witness some overdose cases. So this is the Rome Consensus platform, where you can find our manifesto and our initiatives. Any people from any corner of the world can apply as individual or on behalf of their organization. So we are very happy to share this experience with you. Thank you very much.
Thank you to you, Mauro. So as the speakers were all very disciplined, we can move forward with the questions. Please, go ahead.
Can you hear me?
We have several.
I'm not sure whether I understood the point that you made about the facility, the prison facility.
Microphone. Sorry.
We have several.
Okay, so I'm starting again. Mauro, I have a question to you specifically about this facility you described. I appreciate the idea of something instead of prison, because I'm personally for prison abolition, but I also wanted to understand whether this facility that you were describing was harm reduction-based logic or following more the abstinence-based logic.
The logic.
The logic, like, because you described the facility that is hosting people who have different drug-related offenses, and I wanted to understand whether it's based on the logic of harm reduction or abstinence, because this would be two very different things. And I will just ask questions to everyone and give the microphone back, sorry. And then I really wanted to appreciate all the work that has been done in different prison contexts, and also naloxone focus. And I just want to make a little statement, because we had people from Italy who are in very privileged position, because actually Italy is the only country in the European Union, that has over-the-counter naloxone in pharmacies. What means that if you travel to Italy, just buy naloxone and bring it back and distribute it, because in many contexts it's not so easily available. I know that in Scotland, for example, you can get naloxone for free, but for example, in some countries like the one you are right now, Poland, you can only get naloxone in medical facilities or once the ambulance is called. And people are afraid of calling ambulances to receive naloxone because the police arrives always. So whenever you travel to Italy, buy naloxone, it's 4 to 6 euros. It's really cheap for a human being's life. And it's without prescription. And you can travel with it with a flight or with a train. You can actually legally carry with you 5 boxes of naloxone for personal use. That's entirely legal. Just please do that wherever you can and distribute it in your local communities. Thank you.
Any other questions, or shall we advance with the answers?
Thank you for your question. Actually, we do meet or treat and host more than 700 people every day from the streets to our clinic center. So, of course, in the prison, we do not provide harm reduction activities. We just provide therapeutic support because in Italy, actually, the health public system is regional and provide all the medical assisted treatment they need. But this is not the case in all the prisons, unfortunately. So we can just cover the prison in Rome, and our aim in our project is to divert them to our facility because it's more convenient for all, because they should not be in prison, most of them. First of all, unfortunately, we do not have a huge space to host many of those. Currently, it's a very hot issue in Italy today because we have overcrowded prison, like maybe many other countries in the world. The discussion is open, but judiciary system is very in favor of this. But the politicians, they are, instrumentalize this problem so much, especially in this very moment that we have a very far-right government, and we need to insist a lot on this. But our approach, therapeutic approach, is not the abstinence, because if we do share the idea that a person with drug disorders, the disorder itself is, is that a person in a certain period of the life cannot survive without one or more substances, we do not aim to detoxification. This can be part of the path, but we do not push them to do the detoxification. Our aim is to make sure that they can stay in a safe place if they want to come and join us, or we go in the street and we find them and we provide them all the support they need. Thank you.
Any other question? Just as an information, in 1994, my boss at the time participated in a harm reduction conference, I'm also from Italy, and decided to import harm reduction in Italy. And as he could do it because he worked in a health service, he convened Villa Marini, Lila, and Parsec, and together they imported harm reduction, the first harm reduction conference in the south of Europe. That was the 6th International Harm Reduction Conference. So they are part of culprit if we are here today, probably.
If I may, I add about the naloxone. Indeed, in 1994, we did a huge campaign in Italy, Villa Marini, with other stakeholders to have the naloxone available in the pharmacy. Of course, now naloxone is very cheap in the pharmacy and is available just for €1, but the issue 4 to 6 now with 4 to 6. Okay. But the problem now that we are trying to we are doing a current project for naloxone spray nasal. which is much expensive, but we are distributing this to families and to users because we need to showcase to the government that it's worth it, so that we can also engage law enforcement and first responders to have it. Because since 1980, as Red Cross, we wanted all the volunteers and all the staff of Red Cross in the ambulances to carry on the naloxone. But in many countries, this is not possible because of the law framework. That is not the case. So this will be a very important outcome to also to involve in all the countries Red Cross staff in the ambulances and carry on the naloxone. And because they cannot administer, most of those are not medical doctor in the ambulances, are just paramedic. But the nasal spray naloxone can really make the difference between life and death, and they should be involved in these programs.
Thank you. If there are no questions from the audience, I take the advantage of being here and I ask to you all, are there any programs for minors in prisons? Because I know that this is duplicate the problems because it's the access into prisons and it's the access to minor of age. Still, it is a problem. And also if you have any specific intervention for the LGBTQ plus community, that is also a big problem, and even more in the minor community.
So you're asking about provision for naloxone for minors? Is that the question? Okay, yeah. So we're quite fortunate, obviously, with the nasal naloxone. Legally, it can be supplied to people 14 and over. So as young as 14, they would be able to kind of get trained and get kits. Not every health authority has a policy that supports that, but legally 14 and over, yeah. So I think that's progress.
We don't work with minors, we work with adults. The prison system has a different prison for minors, which we don't access. We access the adult prison. But we can confirm that within the women's ward, transgender people, male to female, are in the female ward, and they're part of our group. They come.
I was asking this question because in a previous life, really centuries ago, I made a research on mineral prisons, and it's amazing the amount of vulnerabilities these people adds up, because in general they are Rome or ethnical minorities, because the other children rarely are put in prison. There are probation systems, there are many ways. And then the people working with them try to keep them in the minor section because going to the adults is exposing to. So I talked many years ago to staff that were in serious troubles to try to protect this population that was disregarded even by the parents. There were children 13, 14 years old already with 30 cases. Nobody cared about them. And it was really, really a severe situation. Luckily, a small group, but really, and then they develop. So if you don't help them when they are so young, what is their future? Is this a question or? No. Okay. If there are no more questions, we can thank everybody. It was a very rich combination of different interventions. Thank you very much. And we can go and enjoy the rest of the conference. Thank you. Thank you, everybody. Thank you.